much, dear dignitaries on dais, off dais. I can see a lot of my teachers here and PSG. Of course, I am also a part of PSG. It was only the first meeting that I missed. After that, I've been associated with PSG and have been the scientific chair for the last few years. So it's really an honor to be recognized by our own parent body as well. So it's a proud privilege to receive this oration, and thank you so much, PSG, for this honor. Well, and this oration is very special because, again, the name of the oration, Professor V. Seshia PSG oration, because I think this is one man who's changed the way gestational diabetes and diabetes in pregnancy has been managed and is being managed in India. And what I am going to do is something that Rutul asked me to take you through, is the evolution of GDM in the last 60 years, ever since OSullivan, and my journey, how it has changed beyond that. So of course, let me start this oration by thanking the universe. I'm a very strong believer in manifestations and a strong believer in gratitude. So thank you to the universe and the God Almighty with all my heart for everything that I have received in my life. And of course, prayers and obeisance to our divine as well as human teachers. I can see a lot of my teachers and mentors. Dr. Chawla is here, Dr. Das is here, Dr. Seshia must be so happy today to receive another oration in his name. So I think without teachers, we cannot be anything. So to start the oration, I think GDM or gestational diabetes or diabetes in pregnancy was something which was not known if you talk about the 1800s, because women with diabetes would not be able to conceive or they would not have outcomes. But the first mention of a diabetic pregnancy has been recorded in 1824 in a Latin thesis by a German doctor, Dr. H.G. Benewitz, where he describes a 22-year-old Berlin housewife going through multiple pregnancies. So, you know, she was giving birth to children who were little bigger. Then, during her fourth pregnancy, she reported increased thirst and glycosuria. They discovered her urine had glucose. It was sweet. She delivered a big baby, and after that the symptoms went away. So they thought this is cured, this condition is cured. Then fifth pregnancy, the symptoms came back with more severity. She reported unquenchable thirst and a cloudy rain-colored urine with the smell of stale beer. She underwent preterm labor. It was a difficult labor, and the thesis describes that the head stuck out like a wedge with shoulders stuck in the womb. The baby was born dead after great struggle, but what they say is the baby was big. It looked like a Hercules baby. You know, that's how they described it in the thesis if you go through this. His shoulders were of such weight that I could not span through the circumference of even my hand. So clearly giving rise to a macrosomic baby which was born dead. So this is the first mention of a diabetic pregnancy way back in 1824. Beyond that, the term gestational diabetes finds its first mention by Carrington in this paper, Evaluation of the Pre-Diabetic State During Pregnancy. And fast forward to OSullivan's paper on gestational diabetes, where he actually mentioned this in detail, unsuspected asymptomatic diabetes in pregnancy. This is what GDM actually, you know, famous all over the world in the global community. And 1957 was the time when the famous OSullivan Mahan criteria for oral glucose test in pregnancy came into being. Fast forward to where we are today. Everybody knows the burden of diabetes is rising. We've been hearing this from the beginning. So the world age standardized prevalence for hyperglycemia in pregnancy is about 19.7%. Southeast Asia takes the lead. Globally, 1 in 5 live births are complicated by some kind of HIP. And in the ideal Southeast Asia alone, 1 in 3 live births. So every third live birth is being affected by some form of hyperglycemia in pregnancy. So clearly in India alone, 2006 we said more than 4 million pregnancies, but now we know it's more than 5 million pregnancies which are being affected by hyperglycemia in pregnancy. So you can see almost 80% of them are gestational diabetes, about 9.9, which is close to 10%, are diabetes which is detected for the first time in pregnancy, but it is overt diabetes. And 11% are people who already have diabetes before getting pregnant, which is pre-gestational, and you can see as the age of the woman advances, the prevalence of hyperglycemia goes up. Now going back again, Conventionally, gestational diabetes was defined as any degree of glucose intolerance with onset of first recognition in pregnancy, regardless of gestational weeks. However, they felt it usually manifests in 24 to 28 weeks. And pre-GDM was any woman who knew that she's got diabetes and was getting pregnant. So this was pre-existing diabetes. Gradually, as our understanding grew, the definitions evolved into women who were diagnosed in the first trimester were classified as having pre-gestational diabetes, and women diagnosed in the second and third trimester, which was not clearly pre-existing diabetes, were classified as GDM. So again, let me take you back to history. So I'll keep jumping back and forth and tell you how things are evolving and how they've evolved. 1926, Lambie in Edinburgh pertinently concluded that when diabetes comes for the first time in pregnancy, it will manifest usually in the 5th or the 6th month. Exceptionally rarely before the 4th month, and again rarely after the 8th month. So this is what the understanding was way back in 1920s. 1954, Haight was the first person who actually gave out a seminal paper with saying that GDM is associated with an increased obstetric risk, and that is why somebody needs to pay attention to it. Glycosuria in pregnancy was usually taken as a first marker of diabetes in pregnancy. Although there were papers, there were people, researchers who were in favor of using it as a marker, and there were people who said this physiological glycosuria, so this may not be the correct marker. However, like I said, though Carrington in 1957 actually introduced the term GDM, but this term gained more prominence after that paper that I showed by OSullivan in 1961 and 1964. Again, White's classification by Dr. Priscilla White from Joslin Clinic in Boston in 1949 actually talked about GDM for the first time, and she gave a classification which kept on undergoing a lot of modifications. Class A was diagnosis of diabetes made on GTT, deviating slightly from normal, eventually going on to diabetes which was associated with complications as well. Now, what is the current understanding? We know we are in the middle of an ongoing epidemic of diabetes and obesity. There's more diabetes and pre-diabetes in women in the reproductive age group. We just heard all this being discussed. So early pregnancy screening becomes very important. Many cases that you pick up early may actually be pre-existing diabetes, which is detected on a routine pregnancy screening and probably was missed earlier because they were never screened pre-conception. So therefore, friends, I think one take home that we need to understand is early pregnancy screening definitely should be done, because this is one thing which has actually increased the diagnosis of dysglycemia in pregnancy, which becomes all the more pertinent. So now, with multiple definitions, multiple confusion, WHO and FIGO have given this umbrella term called hyperglycemia in pregnancy. Pre-GDM is women with known type 1, type 2 or any form of diabetes before pregnancy. Diabetes in pregnancy, or DIP, is an entity which covers pregnant women with hyperglycemia that are first diagnosed during pregnancy, but they meet the WHO criteria of diabetes in a non-pregnant state. That means they have overt diabetes, fasting more than 126, and a 2-hour post value more than 200, or an HbA1c which is already 6.5 and above. GDM, however, are women who do not have overt diabetes. It may occur anytime during the antenatal period and is not expected to persist postpartum. And now we're talking about eGDM, classically less than 20, but now we say even in the first trimester, less than 10 to 12 weeks, and we have a lot of literature coming on that. DIPSI talks about GDM as a manifestation of hyperglycemia in pregnancy, a degree of glucose intolerance with onset of first recognition in pregnancy. GDM essentially represents detection of chronic beta cell dysfunction and is considered a stage in the evolution of type 2 diabetes, and therefore universal screening is very, very important right at the beginning of pregnancy and thereafter in each trimester. Pathophysiology. So earlier, the basic thing was it is basically increasing insulin resistance because of the pregnancy hormones. Then we understood there is a failure in the beta cell compensation and there is already an underlying secretory defect. Now we clearly know it is not just one hormone or two hormones, but the number of hormones that are responsible for the changes that lead to the development of GDM. And emerging evidence now talks about not only the role of insulin secretion, insulin resistance, beta cell dysfunction. The child is born with that. And then the secretory defect that comes in later on. And now we know about the leptin, increased leptin levels, reduced adiponectin, so the role of neurohormonal dysfunction which can lead to GDM, the role of adipocytes in terms of reduced differentiation, increased adipocyte, adipokines, cytokines, inflammation, oxidative stress, gut dysbiosis. all of them lead to pathophysiology of GDM. So I think in the last 60 years, the kind of understanding of pathophysiology of GDM has changed. And that is why we need to give it more importance. Now, evolution of GDM screening also has changed a lot. Till about 1960s, GDM screening was essentially based on a history taking and asking for symptoms like thirst or looking for glycosuria. There were some researchers like Haidt, followed by Dr. Sullivan. So that is where they started talking about using OGTT, glucose tolerance tests. And based on work published by Dr. Sullivan, Wilkerson and Remain in 1957 proposed doing a 3-hour OGTT for patients who presented with risk factors for diabetes. And we all know that family history, gestational glycosuria, or overdeveloped infants at birth. For women without known risk factors, they said a simple 1-hour blood glucose value after 50 gram glucose, the famous GLT, the GCT that we talk about, and a value more than 130 could be abnormal, and then you retest them with a GTT. So till about 2021, the ADA also said, you know, if a woman does not have a risk for GDM, do the screening at 24 to 28 weeks. However, if she has the risk, you can do a targeted screening. So basically, it was only screen the high risk group earlier. Otherwise, you screen all of them at 24 to 28 weeks. But the vision of Dr. Seshia, 20 years back, 2006, that is when he clearly said, no, this does not apply to our population. Asian Indians have we are a high-risk ethnic group for developing diabetes. Indian women have an 11-fold increased risk of developing glucose intolerance in pregnancy, and therefore all pregnant women should be screened at the first ANC visit in pregnancy and every trimester thereafter, and this has been said in the DIPSI guidelines way back in 2006. Now 2025, what do the ADA guidelines finally say? Exactly the same thing that he was saying. So now they say screen for GDM at 24 to 28 weeks of gestation in pregnant women not previously found to have diabetes or women who do not have a risk. But if women have risk factors, you should consider testing in all women for undiagnosed diabetes when they are planning pregnancy. However, women with risk factors should definitely be screened before 15 weeks of gestation. Consider testing them at the first prenatal visit using standard diagnostic criteria if they've not been screened pre-conception. So gradually we are all moving towards the early screening. And of course, you can pick a choice. You can base the IID-PSD criteria. You can do a 75-gram OGTT, or you can do a 2-step strategy based on the work of Carpenter-Couston. I won't go into the details. Now, this is the landmark OSullivan criteria and how they were born. They performed 100-gram OGTTs in 752 women, mainly in the 2nd and 3rd trimester pregnant women. And the Mahan was basically the statistician who actually looked at this data and analyzed this. And they looked at the first standard deviation, second standard deviation, and the third standard deviation upper limits for these glucose values. So this was essentially the first statistically based criteria that actually looked at glycemic normality in pregnancy. So clearly they found that, in normal individuals, they had higher upper limit values at 2nd and 3rd hour, and this was consistent with an IGT in pregnant women compared to the non-pregnant women. So the values they proposed was a fasting of 110, a 1 hour of 170, and 2 hour of 120, 3 hour of 110, and 2 or more values should be considered as abnormal. Remember, OSullivan Mahan criteria was not for diagnosis of GDM. What they did was, originally it was formulated to predict type 2 diabetes in the future in these women and not to actually predict maternal and fetal problems in the index pregnancy therein. So they said women who had these problems do this, and this will tell you whether in the future these women will develop type 2 diabetes. So we have a lot of criteria, a lot of confusion. WHO tried to tell you that 75-gram GTT is the best. Threshold of 2 hour more than 140 is IGT outside pregnancy. Indian guidelines, we all know, DIPSI guidelines strongly tells you single test procedure, just do a 75-gram oral glucose test, 2-hour value with a standardized glucometer. You don't even need to send the sample to the lab. Value more than 140, you diagnose her, and these are the DIPSI criteria. We keep updating the DIPSI guidelines with new evidence. 2023 was the last update, and the next update we are planning in 2026. So a lot of new scientific evidence. We will be incorporating in the DIPSI guidelines again. So the guidelines keep evolving, and this is the latest 2023 DIPSI document, which is easily accessible on the net. So you can go through that, a detailed document on all that I'm talking. So clearly, IDF recognizes the DIPSI criteria, the non-fasting criteria, along with all the other criteria, and since it is something that suits the Indian audience, definitely can be used. GGI and EGI were two terms that were used by Dr. Sunil also. So 2-hour post-glucose, more than 140, you know. This is diagnosed as GDM, you know these women have a future risk of type 2 diabetes. What happens to women between 120 to less than 140? These are classified as gestational glucose intolerance, and we know these women are also having an adverse pregnancy outcome and a future risk of type 2 diabetes. And EGI is early gestational glucose intolerance detected at 10th week. So a 2-hour post-meal value of 110 and above. These are again the women who are prone to develop GDM, impacting the fetus as well. So the fetus also has a high risk of developing diabetes if he is exposed to hyperglycemia, and the mother also from IGT to DM. So that is where the categorization of all the spectrums of glucose intolerance in pregnancy. Now we all know GDM affects not only the mother but the fetus. This is again a background of where did all this theory come in on the intergenerational transfer of NCDs that we talk about. 1920s was the time when Pedersen actually came out with his hypothesis. He was a man who was caring for type 1 diabetes pregnancies. So this is where he said that fetal overgrowth was related to increased transplacental transfer of glucose, and this hyperinsulinemia was responsible for macrosomia. 1980 was the time when Norbert Frankel presented his fuel-mediated teratogenesis concept in the Banting lecture called Of Pregnancy and Progeny, where he said it's not only glucose but lipids and amino acids. So an excess of all nutrients eventually can lead to this entire transplacental priming of the fetus for NCDs. 1980s was the time when David Barker actually published his findings linked to prenatal nutrition and an increased coronary heart disease. So the Barker hypothesis came out in 1990, where he clearly said that low birth weight and intrauterine growth retardation are linked to later life diseases. So on the one side you have macrosomia, which is predisposing the fetus. On the other side you have the low birth weight also, which is again predisposing this fetus. So the whole key lies in having a baby who is normal weight. So the thrifty phenotype hypothesis in the 1990s also talked about environmental factors and epigenetic changes. So the famous HAPO study that we talked of clearly told us that you need to do something, because uncontrolled diabetes, maternal glucose has a direct, clear association with impaired adverse outcomes in the fetus. So this made us sit up and say, no, you need to do something. Now we also have the DOHAD hypothesis, clearly telling us that the environmental exposures, the child is being programmed intrauterine, but the environmental exposures eventually can also lead to establishment of epigenetic modifications. So you have histone modifications, you have DNA methylation, non-coding RNAs, all of which eventually predispose this child to becoming obese, developing diabetes, developing hypertension, developing CAD. So it is not only the mother but the fetus who is getting programmed. So clearly the consequences of the offspring exposed to maternal hyperglycemia throughout its lifetime will remain. And therefore, epigenetic programming has a huge role to play in this entire NCD pandemic. So when you look at the vicious cycle of GDM, 3 critical windows of opportunity. The first one is offer preconception care, prevent obesity, treat PCOS, preeclampsia in pregnancy. A woman who develops GDM, control it so well in hyperglycemia that the fetus is not able to perceive that the mother has diabetes. And clearly, you need to talk about preventing obesity and diabetes in youth if we want to stem this. So Lois Zonvanovic very clearly said, if glycemic control in pregnancy can be maximized to an extent that the fetus no longer recognizes that the mother has diabetes, that is where you say the treatment of the mother during pregnancy may become the first step in preventing obesity and diabetes in the offspring. Management, I won't go into the detailed management. Of course, we know the 4 pillars, MNT, exercise, a lot of debate on metformin, oral drugs, insulin. I won't go into that. Suffice it to say, WHO clearly has told you now that metformin in women where it is not contraindicated can be safely used in pregnancy along with insulin or as a choice to insulin. Glucose monitoring, we know SMBG as well as CGM both are used depending. Type 1, definitely CGM is advocated by all guidelines. Type 2, you have a choice. If she can afford a CGM, well and good, otherwise at least a 7-point SMBG. Glycemic targets, we know as tight as possible. So clearly DIPSI tells you a fasting less than 90 or a 2-hour value less than 120. And similarly, most of the American guidelines also tell you exactly the same. So if you're doing a 1 hour less than 140 or a 2 hour less than 120. So these are the CGM targets, time in range 63 to 140 in pregnancy, and clearly you can see for a type 1, more than 70% time in range is very important, and for a GDM or a type 2, as high as possible, and the SAFE's guidelines tell you more than 90%. DIPSI also tells you fasting to be maintained between 80 to 90 and a 2-hour value between 100, 110 to 120 and a mean plasma glucose of 95 to 105. Pharmacotherapy, of course, insulin is the drug of choice, gold standard, does not cross placenta. We had a huge debate on this. Suffice it to say, whatever your patient needs, you have to give it. Metformin, of course, small molecule crosses placenta. I won't go into the details, but clearly, most of the American literature still talks about metformin still being something doubtful, restricting the use of metformin in settings where insulin has logistic or compliance issues. However, if there is growth restriction, acidosis, placental insufficiency, metformin should not be used. So only those contraindications you need to remember where metformin should not be used, otherwise it can be safely used. FIGO endorses using metformin along with insulin. Similarly, you have the DIPSI document which tells you insulin is definitely the gold standard, but in Indian experience, I think a lot of our OGCN friends will agree with me. We've been using it right from preconception throughout pregnancy and even postpartum without any problems. WHO recommendations again tell you metformin can be safely used. And with that, my journey with diabetes and pregnancy, it's not as long as 60 years because probably I wasn't even born at that time. So, but my journey with pregnancy started as a student 25 years back when I was attending most of these RSSDI DIPSI conferences as delegates, listening and learning from stalwarts, many of whom I can see here. And then I've always been, propagating, talking, and, this concept. Our literature, 2019, this was a paper that we published on early gestational diabetes, a poster in IDF 2019, EGDM that we're talking of. This was the first work. This is a joint work. Dr. Chawla is here. His center and my center, we pooled our data, and we actually looked at 750 women, out of which 93 women were diagnosed with GDM. And here we were able to actually pick up gestational age at screening was 7.2 weeks. And these were women where the HbA1c was less than 5.5. So they were not over diabetes. So this is our Indian data on early GDM. This is another paper, Dr. Chawla and my joint paper, presented in ACE 2024, Screening and Differential Risk Factor Assessment, where we said that, when you're doing GDM screening, 20 females, so 4% we were able to pick up in the first trimester, 7% in the second trimester, and 7% again in the third trimester. And out of them, the women who were picked up in the early pregnancy, the first 2 trimester, these were women who had higher BMIs, predictably, who had a history of PCOS, higher age as primigravida, strong family history of diabetes, or a history of GDM in the mother. So clearly the risk factors predispose you to developing dysglycemia early. This is another paper, and Rutul is a co-author here. Risk factor analysis on GDM across urban India, findings from the PSG group. So here again, first trimester GDM screening, the women who were picked up in the first trimester had higher BMIs of almost 27.9, followed by 28 and 29 in the third trimester, and again multigravidas developed dysglycemia in early pregnancy. This is a paper we published in Endocrine Practice on maternal and fetal outcomes in IAD-PSG versus DIPSI. A lot of people, there's a lot of studies which show that pregnancy goes well. You diagnose via DIPSI or you diagnose via IAD-PSG. Maternal outcomes are studied. Nobody looked at, this was our Indian data on fetal outcomes. So one arm was women who were diagnosed by the DIPSI criteria. One arm were women who were diagnosed by the IAD-PSG criteria. And we looked at fetal outcomes. Paucity of time I can't show you, but we were able to show clearly that there was no difference. So even if you are using DIPSI screening criteria, maternal and fetal outcomes were exactly similar. I can share the study with you off the stage if you need to go through it. So again, talking about creating awareness amongst young girls, school children, in public domain, because I think you need to start talking to the adolescents and the girls on the importance of glycemic control when they get pregnant or not getting obese. So healthy lifestyle is something publishing papers. So I think my journey with DIPSI, this is release of our DIPSI guidelines, 2016 management of labor, pregnancy, hyperglycemia management. This is the RSSDI guidelines, and I've been part of the diabetes and pregnancy author group along with Dr. Sunil Gupta sir. Some chapters in different books. So the work that we've all been doing, this is again GDM ACE. This is our recent paper where we've again looked at early GDM in Asian Indian women, dual center. Dr. Rajiv Chawla is here, his and my data on first trimester GDM screening in early trimester. So I think it's been a great journey all these years. This is the DIPSI declaration. So we have a DIPSI declaration which was released by the Honorable Minister Dr. Jitendra Singh, a futuristic approach towards primordial prevention of diabetes that we talk about, screen early, pick them up and treat them. So the declaration was to actually stop it in its tracks, and this is what we're doing, taking over as the DIPSI president and the RSSDI Nadgowda lecture, and this is where again I spoke about GDM and early screening. Thankful to my colleagues and friends who have been part of my journey all through this, and a lot of them are here. My family, who've always supported me in my journey, my work all the time, and of course, my patients, my mentors and my patients who have been part of this journey all throughout. Thank you so much. So to conclude, I think we as clinicians are afforded the rare opportunity to alter the natural course of disease and change the future health of women and their offspring, which is my mission and my passion. So like Dr. Seshia says, to achieve a diabetes-free generation, it's important we focus on the fetus for the future. Thank you so much for this oration. Thank you.
Thank